Good afternoon, actually good evening. In our third lecture, we are going to talk about gastritis and peptic ulcer disease, very frequent in general population. So probably most of you have been exposed to these terms from even your relatives, and they would ask you, oh, you are a medical student, so I was diagnosed with gastritis or ulcer, so what it is and how can it be treated? You would already have been exposed to these questions, probably. Gastritis, or sometimes gastropathy. So gastropathy means that there is an morphological abnormality in stomach mucosa, but there is no real inflammation. So if inflammation is present, it is called as gastritis. The cardinal example, for example, for gastritis is Helicobacter pylori gastritis, and as to gastropathy, bile acid gastropathy. Helicobacter pylori associated gastritis is very frequent in society, and it is called as type B gastritis. Helicobacter pylori is a gram-negative agent, which is not a physiological resident of stomach, but it is very frequent. And in the first stage, it increases the secretion, acid secretion of stomach. Then gradually it causes atrophy. So not a beneficial agent. So it should be treated. But because it is very frequent in general population, even without dyspeptic symptoms, it is controversial whether all these HB positive subjects should be treated or not. But there is a general agreement that if the patient has dyspeptic symptoms and HB, Helicobacter pylori, is positive, then he or she should be treated. But if there is no symptom, and if in case it is discovered incidentally, it is controversial whether to be treated or not. Actually, in the areas in which gastric carcinoma is frequent, then it may be necessary to treat, because we enlist Helicobacter pylori as an agent which would promote cancer. Autoimmune gastritis is another type of gastritis. This is called as type A, and it also results with atrophic gastritis. In this disease, there are antibodies against hydrochloric acid secreting parietal cells. We do not know the reason, but body is producing such kind of antibodies that results with the destruction of parietal cells, and the eventual result is atrophic gastritis. In any type of atrophic gastritis, whether due to H. pylori or autoimmune gastritis, the risk of gastric carcinoma is increasing. In the course of atrophic gastritis, intestinal metaplasia is happening. So intestinal mucosa is replacing classical stomach mucosa. And in these patients, there is an 0.5% per year risk of gastric carcinoma development. So 5 in 1,000 of these subjects will develop yearly carcinoma. It is a very, very low rate, but it is still increasing the gastric carcinoma frequency. And these patients, atrophic gastritis patients, are having a risk of gastric carcinoma 5 times more than somebody without atrophic gastritis. In these patients, in addition to the treatment of the symptoms, we pay attention to surveillance, at least 2 yearly gastroscopy and biopsies. in order to detect carcinoma if it develops in early stages. Another type of gastritis is an interesting and very rare eosinophilic gastritis. This is an gastritis without an known etiology, but its treatment is different from other types of gastritis. So in any case, if in any type of gastritis, we generally take biopsies to detect these rare conditions. In reference to gastropathy, there is no inflammation. There are two main types of gastropathy: bile acid gastropathy and portal hypertensive gastropathy. Bile acid gastropathy is due to duodenogastric reflux. Duodenogastric reflux means that duodenal content is regurgitated into stomach. This is something abnormal because the secreted bile should go downward. If it is coming back to stomach, it would cause an gastric damage, and in some cases, even esophageal damage. It is very common. It is mostly happening in patients who had gallbladder disease or cholecystectomy, but it also happens without gallbladder disease, and it is mostly common in patients with gastric surgery. Portal hypertensive gastropathy is another type of gastropathy that happens in the course of portal vein thrombosis or liver cirrhosis. So if there is an increase in portal pressure over 10 centimeter, then portal hypertensive gastropathy develops due to vascular alterations. And it is common in patients with cirrhotic disease. Actually, HP is present in 2/3 of the Turkish population, and mostly, as I told you, it is asymptomatic, but eradication is effective if it is causing dyspeptic symptoms. And in general, in especially young population, less than 40 years of age, if there are no alarming symptoms like weight loss and nausea, vomiting, especially vomiting, we generally test stool for H. pylori, and if it is positive, we treat them for H. pylori in the first stage. If the patient does not improve, then we would perform gastroscopy. So in the first place, in dyspeptic symptoms of younger patients, it is better to follow the strategy of test and treat. Test and treat strategy means that you test for HP in stool, then it's positive. If it is positive, the patient is automatically treated for H. pylori disease. Furthermore, even the patient is asymptomatic, but consuming non-steroidal anti-inflammatory drugs, it should be eradicated, because we know that in patients with NSAID use, the presence of H. pylori is increasing the rate of peptic ulcer. You remember I told you in NSAID use, the rate of peptic ulcer is increasing. So this patient should be treated. And another concern is that it may lead to atrophic gastritis. And even if it is treated after the development of atrophic gastritis, this is mostly irreversible. So we are still in doubt. I mean, it's a controversial issue whether to treat all the patients with HP or not. But some people are saying that it is not a natural resident of stomach. So in any case, even the patient is asymptomatic, it should be treated. It may make sense, but it is not a universal rule to treat all the patients, because it may lead to gastric cancer in a very low minority of HP-impacted patients. However, if you look at the matter from the other side, you will see that 90% of gastric cancers are resulting from HP infection. So if you perceive the matter from HP positivity side, then a very low minority is developing carcinoma. But if you perceive the matter from the side of gastric cancer, 90% are having HP infection. In autoimmune gastritis, there is hypoacidity and hypergastrinemia, megaloblastic anemia due to the deficiency of intrinsic factor, and it may lead to dysplasia and cancer. So in autoimmune gastritis, as I told you, we are very careful for the development of gastric cancer, and we perform surveillance endoscopy. Bile acid gastropathy, as I told you, is most common in patients with gallbladder disease or cholecystectomy, but it may happen idiopathically. It is called as duodenogastric reflux as well. And bile acid is very harmful to gastric mucosa, even more harmful than hyperacidity, because it is alkaline, and alkaline damage is most of the time more prominent than acidic damage. And symptoms are the same with any type of gastritis. So you cannot differentiate according to the symptoms between different types of gastritis. And it is a very difficult to treat condition. For example, in HP gastritis, when you administer relevant treatment, the patient would improve completely most of the time. But in bile acid gastropathy, there is no specific treatment. And in most of the time, even if they relieve of their symptoms for some times, there may be recurrences. So this is a very difficult to treat condition. When we come to the sister disease, peptic ulcer disease, peptic ulcers mainly present in duodenal bulb, and I told you in introduction lectures, and sometimes in gastric body and antrum. The etiology is mostly chronic Helicobacter pylori infection, but it also happens, especially gastric ones, are happening due to NSAID drugs. It may be related to aspirin as well. And in some studies, it was shown that 20% of the patients who are consuming aspirin, there may be some changes in gastric mucosa. And nowadays, most of the people are using aspirin to prevent heart conditions and vascular conditions. However, it is a controversial issue. So we do not know whether to use aspirin purely for the prevention of cardiovascular disease is making sense or not, because there is a very high rate of gastric conditions. Of course, if the patient is using it for some very rational reasons, like stent in coronary arteries or ischemic attacks of brain or some types of established vascular abnormality, of course, it is necessary. But if it is used purely for prophylaxis, I don't think it is having a consistent base. And in gastric ulcers, we are trying to differentiate them from malignant ulcers because they may be confused. And we perform always biopsy for gastric ulcers. But in some patients, even biopsy may be negative in a rare patient. So in endoscopy, if we suspect gastric malignancy, and even if biopsy is negative, then we repeat it. Most of the ulcers are healing spontaneously. In 2 weeks, 60% of ulcers are healing spontaneously, so very high spontaneous healing rate. But they may also result with complications. What are the complications? Mostly bleeding. Bleeding is the main complication of peptic ulcer disease, and we very frequently observe. So most of the patients are admitted with upper GI bleeding in our clinic, gastroenterology ward, are having duodenal or stomach peptic ulcer disease. Rare complication, perforation. Perforation used to happen frequently in the past, say 50 years ago, but nowadays it is very rare because there are very effective diagnostic tools like endoscopy And PPI treatment and HP eradication is very effective in healing ulcers. So perforation is rare, but it still happens. Another complication which is still present is pyloric stenosis. If the ulcer in bulb or prepyloric area is a large one, and if it heals with a cicatrice, fibrosis result heals with fibrosis development, which is called as cicatrice, then pyloric stenosis may develop, and it causes gastric outlet obstruction. It is also rare, but happens. And the most rare one is penetration to pancreas. In the past, it used to happen, but nowadays it is very rare. The ulcer in stomach or bulb may penetrate into pancreas. These are the graphic demonstrations, ulcer in bulb and stomach. In the development of peptic ulcer disease, this mucus layer is very important for prevention. So this mucus layer is covering the inner side of stomach, above parietal cells, and it prevents big diffusion. Big diffusion means that the acid secreted from these cells cannot return to them. This is called as big diffusion. But if this mucus layer is damaged, it may be damaged with the presence of Helicobacter pylori, with the consumption of non-steroidal anti-inflammatory drugs, and even with aspirin. So in this case, you see that the inner wall of stomach is prone to be damaged by acid. And in this case, this big diffusion would cause ulcer. And this is the demonstration of an ulcer in stomach with gastroscopy, and the ulcer after gastric resection. And you see that there is a pili convergence here, which is a characteristic sign of peptic ulcer disease. I guess that will be all for peptic ulcer disease and gastritis. In the next lecture, we are going to go on with reflux disease. Thank you.